This talk will cover the assessment of a patient with chest pain. So there are three main parts to this talk. Firstly, we'll look at the causes of chest pain, highlighting those that require urgent attention. We'll then look at key points in the history of a patient with chest pain. And lastly, we'll take a brief look at what basic investigations you may want to carry out. As you can see, there are many causes of chest pain, but thankfully most are benign. The two most common causes of chest pain are musculoskeletal and gastrointestinal. Musculoskeletal chest pain may present after a traumatic injury, but often no direct cause can be identified. Reflux is a common example of gastrointestinal cause of chest pain, and it often mimics cardiac chest pain. Patients with coronary artery disease often have chest pain on exertion that gets better with rest, and this is called stable angina. And pneumonia may also present with chest pain and also comes along with a productive cough. The bottom five are causes that require more immediate intervention. Acute coronary syndrome is what jumps to people's minds when they think of chest pain, and this is more fully covered in a separate talk. Pulmonary emboli and pneumothorax are two respiratory causes of chest pain that require urgent treatment. Cardiac tamponade and aortic dissection are rare causes of chest pain but can be fatal if missed. Cardiac chest pain typically is dull, central and crushing in nature. It lasts for a prolonged period of time and does not get better with rest, often radiating to the arm or jaw. It's often associated with nausea and vomiting. And when talking to the patient, they may have a cardiac history, they're more likely to be a smoker, have hypertension, and a positive family history for cardiac disease. Musculoskeletal chest pain is often associated with an injury or perhaps a sporting event. The pain is worse on movement, and the pain is reproducible on palpation. There may also be some pain on deep inhalation. Gastrointestinal chest pain often is worse with food or drink. It's worse when the patient lies flat, and is relieved by antacids such as Gaviscon. And pneumonia, patients will also often come in short of breath. They will be more systemically unwell, for example having a fever, and they'd often be productive of green sputum. Patients with pulmonary emboli come in with a shortness of breath, and they have a sharp pleuritic type pain that's worse on inspiration. During your history, they may find out that they have had immobilization, for example a leg cast or been in a long haul flight, and they may have a positive history of deep vein thrombosis. So your investigations will be based on the history and examination. For all patients, you want to record basic observations such as temperature, blood pressure, heart rate and respiratory rate. You want to do an ECG in all patients with chest pain, and that's looking for any changes in the ST segment, any bundled branch block or any arrhythmia. A chest x-ray is useful for diagnosing a pneumonia or a pneumothorax, and it may also give an indication of some cardiac disease. You want to do some bloods as well. If the chest pain is cardiac sounding, you might want to do a troponin. You want to do a baseline Usinese. Full blood count may point towards infection, and if you're thinking of a pulmonary emboli, a D-dimer may help the diagnosis. So to summarise, chest pain is a common presenting complaint, and thankfully it's often benign. A thorough history and examination is the key to a correct diagnosis. However, care should be taken not to miss any life-threatening pathology. Thank you very much.